Hello, welcome everyone. Hi, I'm Kate Warren, Executive Vice President and Executive Editor at DevX, and I'm delighted to be moderating this very timely and important conversation on the state of funding for sexual and reproductive health and rights, or SRHR, in partnership with DSW. At DevX, if you have been reading our newsletters, you know we've been closely tracking the shifting global health landscape, especially in recent months as funding declines, budgets tighten, and geopolitical pressures really mount, all while the needs for services continue to grow. And SRHR has always faced headwinds when it comes to being a funding and political priority. But this is really only heightened in the context of dwindling resources and growing demands. As we'll learn in our event today, as the data shows that nearly half of OECD DAC donors spend less than 2% of their official development assistance on SRHR last year, despite strong policy commitments and public support. And that disconnect really raises important questions around accountability, priority setting, and the future of development finance. So we're here today to explore those questions, starting with the launch of DSW's 2025 Donors Delivering for SRHR report. We'll hear some takeaways from the report and talk to a range of voices from donor governments and multilateral actors to researchers and frontline implementers on how the SRHR community is navigating this moment and what might lie ahead. First, to kick us off, I would like to share some welcome remarks from Natalie Kanem, who is the Executive Director of the United Nations Population Fund. So we will play a short video from her now.
Dear partners, dear friends, dear young people, in this challenging environment of shifting aid, the landscape tells us we can't abandon the world's women and girls. They need us now more than they ever have. Development assistance, yes, reached record levels as recently as the year 2022, but that's cold comfort for women and girls who are feeling the impact of steep, unprecedented funding cuts this year. The cuts happen at a time of soaring humanitarian need, and it's a time when funding for sexual and reproductive health services in crisis settings isn't keeping pace with demand. It's really hard to put into words the devastating impact that this has on women and girls in some of the most difficult places on earth, but I'll try. Gaps in funding mean that a displaced woman seeking contraception will find, after walking hours to a clinic, that the door is closed. Cuts mean that women will give birth alone, without any skilled hands, putting their own life and the life of the newborn at risk. Cuts mean that survivors of gender-based violence who are seeking refuge are going to be turned away. And in some cases, it's going to force them to go back to the tormentor that they are trying to flee. As a sexual and reproductive health and rights community, we've joined forces lately at the Nairobi Summit, at the ICPD 25, where we made many commitments, over 1,000, and most have stuck until this day. But tell me, are we sticking together when it comes to communicating the needs on the ground? Are we sticking together and going forward jointly with a plan? Or are we going one by one, piecemeal, seeking funds that women and girls need for their survival and for their well-being? It was Frederick Douglass who said, "Power concedes nothing without a demand. It never has, and it never will." Heeding those words implies that we need to do better. We need to do better together for her.
Well, thank you to Natalia. I think those were really great words to start this conversation on. And I'd like to start off with introducing Lisa Gorlitz, who's head of the Brussels office at DSW, and Nia George, advocacy officer, also at DSW. You are just launching this new report on the donors delivering for SRHR. This is looking at data from 2023. So could you talk us through, what does the data say? What are some of those key takeaways that you found to help ground the conversation? Lisa, yeah, I'll welcome you.
Thank you so much, Kate, and thank you also to all of the wonderful speakers who are joining us today for this discussion. DSW is a firm believer in advocacy recommendations that are substantiated in reliable data. We believe that NGOs like us, but also communities and even governments need evidence to understand how ODA funds are being used to guide decision-making and resource allocation, and also to identify gaps. The report has been endorsed as important accountability tool by many decision makers over the years. You can see some two recent examples on the slides. And I hope you will enjoy hearing about the results of the report. But Nitya, can you maybe tell us first what we track?
Sure, I'd be happy to. Thanks, Lisa. So the donors delivering methodology aims to capture the full breadth of SRHR as defined by the Guttmacher-Lancet Commission. This means especially acknowledging the rights-based approach of SRHR and the interlinkages between health, human rights, and gender equality. Of course, to provide a more complete and differentiated understanding of each donor's profile, we do also track how funding goes to two overlapping and related categories, which are FP and RMNCH, as you can see on the slide. And we use existing methodologies for this analysis. These are the revised Muskoka and the Muskoka 2 methodologies. On the next slide, we'll see how exactly we track this data. If we could have the next slide, please. Thank you. So we use publicly available data on the OECD Data Explorer, where OECD DAC donors report on the funding that they provide under specific CRS or purpose codes. For this year's analysis, we consider 32 OECD DAC donors. However, I should mention that with Latvia joining recently, there are now 33 members in that group. The SRHR funding tracking methodology that we use is unique to the Donors Delivering report. It was last revised in 2023 through an expert consultation. And during this consultation, an extensive analysis was conducted on SRHR projects, the CRS codes under which these are reported, all with the objective of understanding exactly how much of these allocations do truly go to SRHR. So based on this, we now apply imputed percentages to the relevant CRS codes that were identified. And of course, we also do account for both bilateral and multilateral funding so that we have a full picture of SRHR funding. Now, let's dive into the report's findings. Lisa, would you be able to tell us a bit more of the overall trends in 2023?
Sure. Unfortunately, I have to share the bad news first because total donor investments in SRHR amounted to $10.8 billion US dollars, which was actually a drop of $4 billion US dollars compared to 2022. But on the other hand, this 27% decrease is largely due to reductions from the EU and also a substantial decrease from the US side. It is important to note, however, that these reductions might, at least in part, be linked to timing and spacing of bigger contributions than to actual intentional decreases, because to a certain extent, it's always normal that there would be fluctuations in annual funding levels. Because SRHR funding did not grow at the same rate as overall ODA in 2023, the share of ODA dedicated to SRHR decreased to a disappointing 4.3% in 2023, while in 2021 and in 2022, it had been over 6%. So shockingly, if we take the US out of the equation, the remaining 31 OECD DAC donors only dedicated 2.6% of their joint ODA to SRHR, which leads us to the next slide and the question, where does the SRHR funding come from?
Thanks. So as Lisa mentioned, the US is indeed a major contributor. The graph on the left shows us that the US accounts for 54% of all 2023 SRHR disbursements, continuing to be the largest donor both in terms of absolute and relative terms to SRHR. It's important to note that at least until recently, more than half of the US's SRHR funding was linked with support to STD, HIV, and AIDS. And so considering recent funding disruptions to PEPFAR, which is the US's main HIV initiative, it remains to be seen what these numbers could look like in coming years. Another interesting donor group are the EU institutions and the EU member states, which is in dark blue in both of the graphs that are provided. If you look at the graph on the right, we see that the EU institutions and the EU member states together are the largest ODA donor, responsible for nearly 50% of ODA in 2023. However, the graph on the left shows us that they are much smaller actors when it comes to supporting SRHR, jointly contributing only about 23% of total SRHR disbursements. So these are disaggregated by donor groups. On the next slide, we can take a look at what SRHR disbursements look like by individual donors. It's not surprising, of course, that the bigger economies with bigger ODA budgets will also naturally tend to provide larger amounts of SRHR disbursements, as can be seen from the top 5 countries that we have listed here. As mentioned before, the US continues to be the largest SRHR donor, investing 5.8 billion USD in 2023, which is over 9% of its ODA. The UK, another long-time SRHR champion, ranks second with over 1 billion USD invested. And these are followed by Germany, France, and Canada, all at around the 500 million USD mark. And we will certainly discuss this in the panel later today, but we are now aware that at least 7 of the top 10 ODA donors have announced or even partially implemented drastic ODA cuts since this data, so in 2024 and 2025, and the repercussions of this remain to be seen. But before we get into that, Lisa, could you tell us a bit more about which donors actually champion SRHR in their ODA?
Yes, because we want to put these numbers into perspective, of course, and rank donors not only according to their absolute disbursements, but also in terms of how do they prioritize SRHR as part of their ODA. And 7 donors clearly emerge as champions because they have allocated more than 5% of their ODA to SRHR. Interestingly, as in previous years, we can see that the sometimes considerable amounts of SRHR funding from larger donors can represent only small fractions of their total ODA, which is, for example, the case for Germany, who ranked 3rd in terms of absolute funding, but ranks 21st in terms of prioritizing SRHR because it spends less than 2% of its ODA on SRHR. And the EU institutions, for example, dedicated less than 1% of ODA to SRHR. It's worth mentioning, though, that some of the smaller economies do champion SRHR. They do rank lower naturally in terms of absolute disbursements, but they are, for example, Luxembourg and Iceland dedicating more than 5% of their ODA to SRHR. And you can find more information about each individual country profile in the report. The next slide shows what those country profiles look like. You will find a description of the policy commitments that donors made, or maybe the lack of policy commitments. And you can see the funding trends developing for SRHR, family planning, and RMNCH. And this year's report, for the very first time, also includes impact data that we drew from the Guttmacher Institute's Family Planning Impact Calculator tool. And on the final and next slide, I believe you can find a QR code if you would like to access the report. Thank you very much.
Thank you, Lisa and Nidya. Yes, and we also have a link to the report in the chat, so encourage you to follow that so you can dig into all of those numbers later. But thanks. I think that really helps set the stage for our next conversation. And I'd love to welcome Dr. Dube Samukaliso, who is the Executive Director of FP 2030, a global partnership dedicated to advancing voluntary family planning. So Dr. Samu, I'd like to welcome you on.
Thanks, Kate.
Yeah, thank you. So, it's really interesting to hear that data and also acknowledging it's from 2023. We are now in 2025, seeing the US as a largest donor. And, I don't think that picture has improved at all in the past few months. And we definitely have seen recent cuts to broader development assistance, particularly global health. So, as you think about both within and beyond SRHR, what are the real impacts that you're seeing on these recent cuts to broader global health, but also specifically SRHR assistance and the work that you're doing?
Thank you for that question, Kate, and good morning, good afternoon, or good evening to our listeners. The question is, what is happening right now, like short term, the immediate impact? It has been panic. It has been a chilling effect in that we have seen many people who have been in the front lines of service delivery lose their jobs and service disruption in many countries that have made an FP 2030 commitment. Kate, what is at stake and the risks that we are seeing is not only service delivery disruptions, but the ideals that the global health community has been leaning on being disrupted as well. So for service delivery, we're seeing absence of services that we've been relying on for our attainment of sustainable development goals. We are seeing the quality of those services being at risk, because when we talk about quality, we are talking about method mix when a woman goes to the clinic. And if you do not have an IUD or an implant because the container is stuck somewhere and could not be delivered, that is service disruption. But for SRHR programs, many of them were really reliant in some of the countries on USAID's global health architecture that existed at a country level. And when that has been taken away, you then find that many of the countries who were relying on USAID are now at risk of that service delivery disruption. What is also happening is that the road to self-sufficiency that we talk about, we have been using ODA to ensure that countries go towards self-sufficiency as we move towards 2030. Are we going to attain that? Probably not in terms of where we are, because ODA is supposed to be catalytic funding to ensure we gap those inequities that we see, especially access for SRHR services for adolescents, for marginalized people. We are not seeing that anymore. And also, countries that have made compacts with UNFPA, for example, to ensure there is commodity security at a country level, they may not be able to apportion funding for that, and that actually does affect service delivery. We are also seeing what we're trying to achieve towards 2030 in terms of economic growth, in terms of economic power for women, educational goals. That too is at risk. And when that is disrupted, what is now even at more risk is political will at a country level to ensure they uphold those ideals and global commons that the world has been really relying on.
Yeah, so thank you. So there's both at the international and even at the national level, these challenges for both political and financial prioritization. And so how do you think about making that investment case? We have dwindling resources, cutbacks. Like, what is the case for investing in this issue amidst all the other competing health and development priorities?
And the case we have met, we believe, Kate, that we have been making the case for a long time. And we think that investment case is not going to be sort of diminished by whether we increase or we reduce funding. That investment case has been there for a long time. And I think my colleague Jonathan will attest to that from Goodmarker. Now, we believe that we just need to sharpen that case, because where we are, there is risk that people are going to be selling their groceries to buy their refrigerator to buy groceries. If you don't invest in family planning, if you don't invest in reproductive health and rights, you will slow down economic growth that you wanted for your country, women's economic empowerment, and even educational or even maternal mortality reduction goals that you have. There is no way a country can leapfrog development without investing in sexual and reproductive health. So the investment case for us, Kate, is number one, this is the right thing to do. attaining reproductive freedom is the right thing to do. The second thing, it makes economic sense. We have seen over and over again that every dollar that has been invested in family planning yields eightfold in many other areas. For example, in women's economic power, we have these yields that we have displayed in front of ministers of finance, in front of ministers of health, or even ministers who are in charge of economic development in their countries. This is important, particularly when you invest in adolescents. We know that the economic power for women that you attain when you make those investments is even more profound. So I think the investment case is there. The investment case now, who is it going to be directed to? Not only domestic governments that have been affected by these cuts, but also for the global solidarity that we are trying to build. I think for countries that have been donor countries for a long time, there is still an investment case to be made for the world that we want, a world where everyone is able to thrive and even transcend. So the investment case is both ways, to individuals, to communities, to countries, to ODA, for ODA donor countries, so that we do attain what we are trying to achieve by 2030, Kate.
Yeah, and you mentioned obviously the challenges both at the national level, and what is the role of civil society in all of this in helping to not only make this case, but really advocate and push for these policies?
Mm-hmm. That's a great question, because we are seeing an evolving role for civil society maybe going forward. First, I think civil society was there for accountability, ensuring that commitments that governments have made are realized in one way or another. But I think we now need civil society to even be more sophisticated, Kate. Number one, I think civil society needs to be familiar with the language of where else can money come from. It's not enough to just say, put more money, because the government is going to open their books and say, look, this is the budget that I have. So how do you have a conversation that says, where else can money come from? I think it's time that civil society understands the language of social impact bonds, of health debt swaps, of how to structure some of these financial instruments that can help their governments move forward. But in an environment where we are seeing shrinking democratic spaces, we worry that for many civil society organizations who would have been funded by ODA, their lights may not be on. So we need civil society to be in the forefront to actually come and work alongside with governments to ensure that we actually jump this particular crisis and see it as an opportunity for progress at a country level. I think the other role that civil society needs to play is to ensure that community-led and community-driven solutions, especially around how else are we going to finance SRHR, they need to emerge from there. There are examples. In Nigeria, there's the civil society that has been saying diaspora need to adopt clinics at a local level, fund those and ensure there is governance within those clinics. There is a civil society that is ensuring in programs like TICO in Kenya and elsewhere, where social impact bonds are being modeled. How can civil society partner with community-led initiatives to ensure there is access to SRHR? I think the role of civil society needs to emerge stronger amidst this, so that we partner with governments in that service delivery.
Well, thank you, Dr. Samu. We'll continue this conversation. I'm going to bring in the rest of our panel, and I'll want to bring you in later into the conversation too. But please let me introduce our panelists for the next conversation. We have Dr. Carol Sakempi, who's the Senior Africa Director at MSI Reproductive Choices, Jonathan Wittenberg, CEO and co-director of Guttmacher Institute, Agnes Sukat, who's the Director of Health and Social Protection at the French Development Agency, and Almut Knopp, who's head of division for SRHR and social protection at the German Federal Ministry for Economic Cooperation and Development, or BMZ. So thank you all for joining us for this important conversation. So I want to begin with you, Carol. And MSI provides life-saving SRHR services across the African continent. We've heard about the cuts I've seen from several DAC donors. We've heard from Dr. Samu and Natalia Kanem at the beginning, some of the immediate impacts. But could you talk a little about what you're seeing and your challenges and ability to maintain coverage, particularly in low income and fragile settings right now in this moment?
Thank you very much, Kate, and welcome everyone to this conversation. The data that has been presented up to this point has been very insightful to tell a fuller story. And while the decline in ODA has been gradual over the last couple of years, we really must articulate that it has been exacerbated since January, when we had the US government stop work orders, and then we went into cancellation of several contracts related to sexual and reproductive health. And while there are several other governments who are contributing to reproductive health, there's no doubt that the US government, as you saw in the data, is the largest donor in this space. So many partners in the reproductive health sector, including MSI, anticipated that there will be cuts in this season because we're having a Republican government coming back to the White House. But no one anticipated the amount of disruption that we have seen since January. And so it is critical to say that the times we're facing are unprecedented. The changes are sudden. And while I'm going to do my best to share some of the things that we see, I think we don't even have the full extent of what's going to happen or what has happened as countries just grapple with the change. So overall, we observe a general upending, a general disruption of the sexual reproductive health infrastructure and ecosystem. Small organizations, grassroots organizations, the ones which mobilize women, the ones which accompany women, many of them closed because they couldn't survive the sudden stop work orders. They couldn't survive the sudden loss of funding. We have lost leadership and ability to coordinate and convene because most technical working groups in countries which were centered around the Ministry of Health and bringing all partners together to discuss work plans and supply chains and who does what was suspended instantly with the stop work orders and the loss of funding. We've seen in several countries closure of organizations, both small organizations and multilateral organizations pulling out and giving notice to pull out of certain geographies. What this means is that in the total cycle for delivery of sexual and reproductive health services, we have missing pieces. In many countries where MSI works during this period, especially between January and about April, MSI was the only partner on the ground continuing to provide reproductive health services. Why? Because we anticipated the change, but we didn't anticipate the extent. So we were working in a way of limitation because the other partners that we depend on for the full service were not in the field. The partners for communication, the partners for supply chain, the partners for mobilization, the partners for advocacy, many of them have left. The other obvious impact that has been touched by several speakers is the loss of funding. But what does the loss of funding mean on the ground? One of the most glaring ones was family planning commodity shortages. And this is just starting. And the impact of this ranges from procurement to commodities stuck at a port to failed distribution. In Zambia, we experienced a freeze, just an immediate freeze in the movement of commodities from the central government warehouse to the field where we provided services. The other thing we observed is loss of health workers, most of whom are midwives and nurses. These ones constitute about 50% of the health workforce, and many of them were being funded one way or the other through funding from the US government. In Ethiopia, we know that Ministry of Health halted payments to all workers who are related to USAID, and this meant up to 5,000 health workers of different cadres could not serve. Some of the health workers are in the field and others are within the Ministry of Health. All departments within the ministries of health within Africa were suspended because of these stop work orders. The other thing that we are seeing is data, loss of data, and inability to track our impact. As we know, the demographic health surveys happen in several countries every 5 years, and they enable us to track where we are on national demographics and what progress we're making on key indicators. Most of these in most countries were funded by the US government. And with the sudden freeze, they are frozen. And the websites in many countries are now down, and it's not possible for you to go in and see the data that came from the last demographic health survey. So you have no baseline with which to plan, you have no baseline with which to think. Health management information systems, HMIs, in most countries have been funded by the US government. So again, MSI in many countries reports into these health management systems and all other partners. So when they are down, there's no data. No one knows how many people are getting implants. No one knows how many women showed up asking for services. So no one can plan for what to do next and where the gap is. The other big thing that we observe after this recent escalation is an emboldening of the reproductive health opposition. Many countries have signed up to the Geneva Consensus Declaration. Many countries, Uganda, where I'm based, has signed up to Protocol, which is the implementation framework for the Geneva Consensus Declaration. And if you read this document, while it has nice language about maternal and child health, it is generally anti-rights and hardly mentions contraception as a pillar for successful maternal child health programming. We have seen a lot of myths and misconceptions going around. Here in Uganda, we had a myth that contraception had been declared illegal, and many women were running to the nearest health post to remove their implant because they thought they were doing something illegal. We've done work to reverse that, but we know there's going to be a lot of misinformation coming. We have experienced media attacks that have become more brutal, more sophisticated, going for individuals like our country directors and service providers. We saw this in Ethiopia, and we anticipate that others will come. We have seen a retrogression in the progress of reproductive health policies. The maternal health bill that was being discussed in Sierra Leone was an exciting piece of legislation that was going to really move on the needle on access of reproductive health and rights in Sierra Leone. It has since frozen. First, there was a bit of a rumor around it being connected to the previous US government administration, and now everyone is too scared to make a decision, and they keep going back and forth. And I don't think it's going to be signed very soon. Recently, there was a big convening of Family Health International, Family Health Watch in Kenya, and we had major powerful people in the sector from governments being represented there. And what they're discussing does not promote reproductive health and rights. Most of it is anti, and it's all being sandwiched in language around family protection and preservation of the family. So we expect to see a lot of these, and we continue to watch and track them as they unplay. Thank you, Kate.
Yeah, thank you. And thank you for giving so many of those examples and really demonstrating the domino effect that this can have and the ripple effect across so many areas. And Jonathan, I'd like to bring you in. And one of the things Carol mentioned was the funding to data and also research. And so now we're in a position of both knowing we have less funding to go to actual work on the ground and also less funding to even be able to measure research, what the impacts of that are. And at Guttmacher, you've been at the forefront of evidence-based advocacy. So when funding to independent research institutions gets reduced, what are the risks and how's that affect your ability to really inform global SRHR policy?
Thank you so much, Kate, and thanks to DevEx. And I also want to commend DSW for their leadership on the Donors Delivering Report. It's an excellent resource. We at Guttmacher rely on it. I know that many in our field do as well. To answer your question, I'll start by invoking the very simple saying that what gets counted counts. And I think this is really especially critical in SRHR because stigma, legal restrictions often push these issues into the shadows. You'll often hear politicians say and get away with saying, this doesn't happen in my country, precisely because we lack data to prove otherwise. And so measuring SRH needs, behavior, services, it's not just academic, it's about making the invisible visible and holding governments accountable for people's real experiences. To your point about independent research institutions, they're absolutely critical because routine government data systems often fail to capture essential SRHR information. The stigma around these issues that I mentioned means that national censuses, health information systems, surveys typically don't focus on collecting this data, especially in countries that lack the resources for large-scale population surveys on sensitive topics like abortion or adolescent sexual health. And so donor funding, like the funding that's tracked by the Donors Delivering Report, is really critical to supporting the data infrastructure that's necessary for tracking and measuring progress on SRHR. And as researchers, I'd say that reducing or eliminating funding really constrains our capacity to monitor trends in progress, to explore the drivers of health outcomes, inequities in access to care, et cetera, and to provide the evidence that's critical to ensure that health and social systems can support the realization of full SRHR by all. And I think Carol mentioned the stark example of the recent termination of the demographic and health surveys, which have really been foundational resources for understanding key SRHR trends for the past 4 decades. And when research like that gets cut, and our data systems are undermined, we risk losing the ability to count and therefore make visible sexual and reproductive health and rights. I want to finally say that on the flip side of the downturns in funding, we have a clear track record that shows how research funding has been a real driver to concrete improvements in SRHR programs, services, and policies. And I'm happy to come back and share some examples of that. But I think it's an important message for donors to get and for civil society to deliver to donors that research really makes a difference, and it's important to continue to invest in it. Thank you so much.
Yeah, thank you, Jonathan. And yeah, talking about the kind of the donor perspective, Almut, I'd like to bring you in. And from BMZ's standpoint, how's Germany working to keep SRHR prioritized in your development cooperation, and especially in this tight fiscal, sometimes highly politically charged environment amidst, many other competing demands?
Thank you for the question, Kate, and also thank you for convening us today and for holding this very interesting discussion. I've already learned a lot. As for the German funding and the German priorities, you described rightly that development cooperation is shifting in its nature, right? It's not what it was 10 years ago. It's more transactional, it's more interest-based, and that's true for almost every country in the world. To different extents, though. I think here we really have to look at the bigger picture. What we see regarding the global gender pushback is super worrying. Growing membership of the Geneva Consensus Declaration, more signatories. This is also of concern to countries in the global north. So in the end, this is kind of a phenomenon that is relevant to all of us. And I think that really is the case in point, that we might, we have to live up and stand for our values. Otherwise, they will be going away at some point in time. As for our priorities recently, right now, as we speak, Germany has just gotten a new government. We had elections, we have a new government. We have a coalition treaty that gladly mentions SRHR explicitly, which I think gives a good basis for further engagement. As for the budget, to be very honest, we have to see, right? So that's not clear yet. We do hope that we don't get cuts definitely not like in the US, but also not like in UK and other countries, but we have to wait. What's going to be there is, that's already for sure. We had the feminist development policy in Germany. I guess the substance of it will still be there and will continue to exist, and that gives us hope. I think what we need now is really strong partnerships together with civil society. We need to be really loud about what's happening there on the ground in countries. You have to have good cases from the global south, coming back to the funding cuts, but also from the global north. And we have to look at it from a very political perspective. Of course, our interest is to protect the work that civil society is doing, also the work that important multilateral partners are doing, like UNFPA, the World Bank, and others. And we also have to build new partnerships for SRHR with countries that maybe have a moderate position. And that I realized that last CPD in New York are kind of shocked by the position of the US and other countries. And then in this shock of the fundamental position they're having, turn towards us. So we have to build cross-regional partnerships and unite about those parts of SRHR that are not as contentious. I mean, 80% or maybe 90% is really not put into question. I think that's an important approach. Last, just to conclude, I think it's we also need stronger coordination with civil society, with multilateral actors, but also within the donor community. In a way, SRHR has always experienced opposition, so we are kind of used to that. We are well organized. We have partnerships, like-minded groups. We stand united, but we could be stronger in that. We could be louder in that, and that's, I guess, something for the next months to come, where we should really be working on. And last point, as SRHR is not only a case in point for itself. There is so many links to contexts of flight and migration, to fragile contexts. I think those are all issues that are so omnipresent in these days' world that we have to look at it a little bit closer. Thank you.
Thank you. Yeah, and I want to follow up on that kind of coordination aspect here and bringing Agnes in. And first of all, ask, how does AFD currently position SRHR within your broader development agenda? And then, what opportunities do you see for stronger coordination among donors?
Thank you. Thank you very much. And thanks for organizing this. This is a very important conversation at this time. First, let me say that there is no question that there is right now a backlash on the women's rights agenda and the sexual and reproductive health agenda. It's a generalized backlash globally. It is in all regions of the world. And I think this conversation really needs to be set in that context, that we've made a lot of progress on sexual and reproductive health rights and access to services over the past decades. But right now, the political environment is generally not very favorable. In that, France, and within a broader European context, is more than ever committed to this agenda. More than ever because we realize that we are facing this backlash, and more than ever, we are committed to it, and we want to be a champion of this agenda. You know that I think we are the first country that has established the access to safe abortion as part of our constitutional rights. And the equality of men and women is one of our 3 priorities in our development aid and global partnerships conversation, together with planet, that is climate and biodiversity, as well as democracy. So we remain committed to a feminist diplomacy, to the equality of men and women, and that in an environment that, as mentioned, that is increasingly challenging, including in Europe, where some countries have actually abandoned this feminist diplomacy. So I make this very strong statement because this is really something very important for us, and we are extremely committed. 2 additional points, actually, regarding your question. I think you presented very nicely the situation in terms of funding. I think what we have to say, though, is this funding represents very small amounts as compared to what countries spend. And the issue of funding sexual and reproductive health is mostly a question of domestic funding. And the issues that are arising with the interruption of USG funding are really mainly affecting a few countries. And these are the low-income countries. You mentioned Ethiopia. Ethiopia is one of the countries that probably is most affected by those cuts. There are a few others. But let's say that more generally, it's a question that is affecting about 30 countries who are the low-income countries. And that really calls into question the entire global health framework we were living in until recently, which really allocated most of development aid to middle-income countries. We've been saying that for some time. We've been calling for a shift in the way development assistance is allocated to really focus on the low-income countries. And I think now we are revisiting the entire global partnerships framework to make sure that the resources that are mobilized from European countries, as we discussed that in the European mode, but from France particularly, focuses on countries most at need. And when we work with middle-income countries and emerging economies, that we try to work as in a model of mutual partnerships in which there is a collaboration that brings together domestic financing together with the assistance that can be brought by external financing. Doesn't really make sense today that continue the old models of dependence, and it's actually a demand from our African friends and counterparts to really develop frameworks that take much more into account that question of domestic financing. We have overwhelming evidence that development aid was displacing domestic funding. Actually, since the announcement of U.S. government decrease in funding, we've seen several African countries which have announced an increase in domestic funding, and that includes Nigeria, 300 million on the domestic budget. That includes Kenya, Cote d'Ivoire, but even very poor countries like Malawi have made some commitments. So we really need to take this sort of historical event as a way to really discuss again the question of domestic funding and the ownership of these programs by countries. And I will finish by echoing the point that has been made on data. I think ultimately that's the most important point, because we know that right now there is disruption of services, of course, because those services were highly dependent on funding from the US government. And they were in many ways organized in a programmatic way in which it was difficult to actually get them integrated in country systems. So yes, there is a lot of issues and a lot of pain right now. At the same time, what worries us the most is at the time where we suspect that women will suffer, that some will die, then children will also suffer, and some will die, that we are actually incapable of measuring that. So we will not be able to actually show that. And that's, yes, we know that, and this is what worries us the most, really, and we are thinking about how to address that in a European organized fashion and working with the European Commission and all the European countries on how we can think about this question of country data and country data production, because this is sort of the last straw on the data system. The whole infrastructure of data in global health was dependent on US money. The US was the government that was insisting on building data system, was funding DHS, it was mentioned, was funding facility surveys, was funding collection of data in HIV services and doing research to understand the patterns of the epidemic. And this is gone. And this, unfortunately, is going in the same direction and what is happening over the past years, in which we have less and less countries reporting country data to the WHO. When it comes to health financing data, you were mentioning the issues with them. In 2022, there were 60 countries less that were reporting country data than in 2019. And it's actually the same for other data. So the WHO relies more and more on modeling but modeling at some point, right, will over time get further and further from reality. Because if you don't feed models with country data, at some point your models will no longer be validated and no longer be relevant. So we're really facing this really, what I would say, the most critical crisis, which is we are in the dark. And we may not even be able to demonstrate this disruption of services with real data. And that's really something that we should, I'm really happy that this diagnostic is shared, and we need to work together on it. And certainly from our side, we're ready to mobilize resources for that. Thank you.
Yeah, thank you. And I think you bring up an important point that a lot of people have been talking about is really this over-reliance on particularly US for health systems, moving away from that, having more domestic ownership, country-led programming is the right path to go. I don't think anyone have chosen this rip the Band-Aid approach that's caused so much disruption. But in our remaining time, we have a question related to this from someone joining about moving towards this country-led emphasis, but how can we effectively meet people where they are, acknowledging local realities and cultural context? We know that this is a more politically sensitive area of health compared to maybe others. And so I'd love, Carol, to get your input on that. And then in our remaining moments, I'd love to hear from each of you all too, kind of where you do see those opportunities. I think it can feel maybe a little unsavory to talk about bright spots and opportunities when we know the backdrop of people's lives being lost. But I heard recently someone say, well, possibilities. So I'd love to end on that. But first, starting with you, Carol.
Thank you very much, Kate. Just thinking about ideas on how to navigate the financial constraints and to get the political will we need. I think the first thing we're thinking about is diversification. Diversify sources of income to fund reproductive health. Generate income. I think for MSI, we have clinics and social marketing. Go for equity for clients who can pay for services, let them pay for them so that the donor funds are preserved for the most poor, unable to pay for services. Diversify donors. Many of us are very dependent on ODA. Can we look at philanthropy? Can we look at impact investing? Can we look at low interest loans, depending on the model that you're going for? I think we have to think in that direction. We need to leverage as much as possible. This is aligned with government ownership. I think for African governments, they have so many pressing priorities. It's going to be difficult for reproductive health and rights to make it to their priority list, but we can leverage the infrastructure they have built for malaria. We can leverage the employees that they're paying already, so that instead of donor funding paying for everything, we can leverage what they have already paid for, so that every dollar goes in the long term. And more importantly is to push for value for money, for every dollar, for every pound, for every euro that is invested, through tracking and measurement and monitoring and adaptive programming. Because as you say, the environment is really quite volatile right now. So we have to keep changing really quickly to give us value for money. On the side of political will, I must say that things are really, really volatile right now, and it is more difficult to navigate in a situation where political interest is not based on values or principles, but it is based a lot in fear and transactional engagement. So that's really, really difficult. But generally, I think we want to know who our allies are, and we want to know who our opposition are. And we have to find the middle ground with each one of them. There are basic things like language. I think during my work in Uganda, Uganda tends to come up as a country that is very not so progressive. But one of the things that we've learned to practice is just the right language. If people want to talk about maternal health as a language that sits well with them, let them use that language. But then when it comes to actual implementation, then let us ensure that all the tenets of maternal health, including post-abortion care, including contraception, are all covered at the point of implementation, so that our politicians are given space to support us. And I think we all have to be really, really compliant by local regulations to the extent possible. Because, in MSI, we use the term of keep your behind door closed. If it is registration, if it is what they are required of NGOs, if it is taxes, if it is all of these things, those of us in this arena where we must be 100% compliant so that we don't put the political forces that are willing to support us in a position where they have to pick and choose. So my quick ideas, Kate. Thank you very much.
Thank you. Yeah, Jonathan, just maybe briefly where you see the possibilities.
Sure. I mean, I think all of that that Carol just said really resonates. I would also highlight the chance to integrate SRHR financing as a core element of universal health coverage. There's been a push for expanded access to primary health care. And some of the services that are most frequently sought by communities are SRHR care, right? Such as family planning. So I think that there's real opportunity there to embed SRHR within UHC. And I think there's a very strong investment case that we can leverage, going back to where Samu started off in her excellent remarks, to help make the case for, again, for embedding SRHR as a core element of UHC. So that's one area of potential that I see. Thank you.
Thank you, Jonathan. Almut?
Thank you very much. I completely agree with what Jonathan and also Carol said. I think when we talk about the new health ecosystem that's just about to emerge, SRHR has to be an integral part of it. And also talking about UNAT, UN reform, that has to go together, cannot be two separate discussions, and financing is part of it. And then I cannot agree more. We have to use the language, although we have to be a bit dogmatic on the political level. I think on the local level, working with the people, we have to be super pragmatic and use the codes. And they are different in every country. I've worked in many fragile contexts, and every country had different language. And last point, I also want to underline that I completely agree that even if donors like France, for instance, have a strong focus on SRHR, which is really applaudable, it will never be enough. Donor money will never be enough to cover all the needs. So we have to think new ways, new financings, and also new areas of where the money is, talking about social protection, talking about workplace measures. So there's many areas where we can or should more inject SRHR. Thanks.
Yeah, I think a lot of people are trying to find where the balance of where to be pragmatic, where to be dogmatic, and yeah, interesting space. Agnes, you?
Yes. So I think if we're thinking about next steps, I think it's really thinking about how we can retool our approach. I think the global health agenda, the way we've been designing it and building it over the past years, is clearly gone. And this is a lesson I learned, in the World Health Assembly 2 weeks ago, listening to the representatives of the countries. There were sessions with ministers of finance, ministers of health. And it was really very interesting how they acknowledged that. And the question is for this agenda, which I think in this meeting certainly all agree on, and we want to continue to promote, and we want to support women all over the world to have access and to have the right to essential services. We really need to develop some mechanism right now to think how to work differently. And as I mentioned, we need to, as an emergency measure, we need to work together at the data problem. We need to work together at looking at the budget dialogue at country level. That means reorienting our advocacy work towards the mobilization of resources from country budget. And certainly when we talk about family planning, for example, we can think about examples in the recent past. 20 years ago, Ethiopia was completely dependent for contraceptives, completely dependent on UNFPA. In fact, this was the way the budget was designed was that way, is contraceptives, UNFPA, there was not even a number. And vaccines, UNICEF. This changed over time, and it took really some advocacy work in using data that came from DHS about what women were asking, what was their demand, what was the unmet need, to actually get the Ministry of Finance behind in actually funding these budget lines and making sure particularly injectable contraceptives were funded from the domestic budget. I think this is the kind of experience that we need to use to orient our dialogue at country level, particularly for those 30 countries that are really suffering from the cuts because they are poor, because their programs are highly dependent on development aid, and because, yes, it's unlikely that there will be much more money coming from the outside in the next couple of years. So we really need to rethink our advocacy, not about raising international funding, but about prioritizing these activities at country level and supporting advocacy platform, women's platform, families platforms that actually influence the process of budget formulation at country level. And this is why we need, all our forces, and particularly forces at country level, women's group, civil society, citizens group, to really be advocates for this. This is. I mean, here we're talking about sexual and reproductive health, but the same conversation is happening with HIV. The same conversation is happening for malaria and for vaccination. It is about governments prioritizing the minimum interventions that make the difference in the life of people. It should be their responsibility. And that's been really, I think, there's been a major realization of that among African countries. There is really a conversation happening at EU level that goes that way. It doesn't say that everything will be solved. We know that, societies are, and I said, there is a global pushback. There are some elements in societies that are pushing back on this agenda, but this is at all income level. It's happening in the US, it's happening in Senegal, it's happening in Uganda. It is everywhere. This is something that we really need to work on, bringing forces that actually influence the formulation of country budgets and get this agenda on country budgets.
Thank you. Well, I know we're running a little over time here, but Dr. Samuel, I did want to bring you in for your final thoughts and reflections too, particularly as we look ahead at what the possibilities are.
Thank you, Kate, for that. And my fellow panelists have really articulated what we need to do in certain areas. I think highlighting and emphasizing a service delivery model that acknowledges that there are some people who we may not cover. The emergence of private sector to not only help us in volume guarantees, but in service delivery, getting those entrepreneurs on the ground to help us with distribution models, access for young people will be reliant on private sector. Let's allow private sector to thrive, and governments need to enable private sector to thrive. The second issue is, Kate, we cannot afford not to double down. Let us double down. We are as strong as our weakest link. Even though we may not be mobilizing for more ODA, we need both grassroots and grass-top approach for advocacy. Let's build global solidarity. Agnes, to your point around that solidarity that we need, my appeal is FP 2030, we are talking to some of the European funders, make an FP 2030 commitment. Family planning is not just important in Senegal, it's also important in France. So making that commitment also as a country helps us to build global solidarity. So that's my appeal also to the funders, that it shouldn't be this dichotomized view of access to SRHR. Let's make it a universal ideal that everybody rallies around. And lastly, Kate, I think we cannot afford not to be in those meetings and conversations around financing. We need alternative methods of financing, including what Jonathan spoke about, universal health coverage. We need innovation, but let not anyone pass a budget that doesn't have SRHR. Otherwise, we are not going to get there strong. We are going to get to 2030 limping as a global health community, and as the field that we're trying to transform so much. Thank you for the opportunity, and thank you to my fellow panelists.
Well, yes, thank you all so much for this rich conversation. Still so much more to dive into. And of course, at DevX, we'll be continuing to report on these. You mentioned financing. We'll actually be in Sevilla for the Financing for Development conference. That'll be happening later in this summer, and looking specifically also at health financing. So we'll see what comes out of those convenings. But in the meantime, thank you all for joining us. Those of you joined us online, and of course our panelists, and thank you to DSW for partnering with us to bring this important conversation to our audience. Lisa at DSW, any final thoughts, reflections to close us out?
Yes, certainly. Let me just say I very much agree with some of the comments shared in the Q&A box that we didn't have a chance to address about increased coordination, and also maybe the need or opportunity to look at climate adaptation funds. But as a final call to action, let me say that as a coalition of SRHR champions, let's try to turn the insights of today's discussion into action and stand up for sustained and equitable funding for SRHR. Let's speak up, show up, and fund up. But also, on the other hand, let's face the new reality that ODA is more and more perceived as a transactional tool, as Almut said, and that we need to not only talk about alternative funding mechanisms, some of which we've heard about today, but also speed up the implementation. Thank you all for joining today, and I hope you enjoy reading the report. Don't hesitate to share your feedback or questions with us, and maybe see you in Sevilla.
Great. Well, thank you all. Yes, and please download the report. I know there's some questions about, we are recording today's session. We'll be sending out the recording. So if you want to share with a colleague or watch anything back, please expect that in your inbox soon. But again, thank you all for joining us, and thank you to DSW.